meantime, throwing a plug out there for everyone. If you're interested, there's the Advanced Regenerative Medicine Institute is putting together another Evolve conference. Of the conferences that the Army puts together, this is a larger production. We have a great group of people coming in, some basic scientists, a lot of physicians. We're going to be discussing or obviously regenerative medicine, but for different approaches. We have sports medicine coming. We have some orthopedic surgery coming, physiatry, anesthesiology, pain management, etc. And I think it'll be a really fun experience for many people. We're trying to make it more innovative. It's a little bit less of the basic sciences, a little bit less of the intro kind of topics, and really just trying to figure out what other people are doing out there in this field, and how to give good education, push the field forward. So I hope you'll join us. It's February 3rd through 5th, the entire weekend, Friday, Saturday, Sunday. Friday is going to be hands-on with live models and live procedures. People always get a lot out of that. You kind of get to peel back the curtains and see what how these things are done in real time in other people's practices, and live feedback on how this is done as well. So I think people get a real kick out of it. I think we should probably get started now. So I have the distinct pleasure of introducing Dr. Kelly Romero. She's a naturopathic physician based out of Arizona, and she's certified in exercise physiology with American College of Sports Medicine. She's the owner of Longevity Medicine and Sports Therapy in Chandler, Arizona, where she specializes in hormone replacement therapy, regenerative medicine techniques, and she has a passion for helping athletes to live their best lives and be their optimal health, fitness, and well-being. So with that said, I'd like to hand the baton over to Kelly Romero, please.
All right, well, thank you very much for the introduction. I'm so thrilled to be speaking about this topic, and I want to thank Army for the chance to talk about postpartum joint pain and how we can utilize orthobiologics. I feel like it's not something commonly discussed in this field, but for me, in my practice, I'm about 50-50 men and women. So 50% men, 50% women. So it's not that I predominantly specialize in just seeing women. This is just something that I've really come to see in my clinical experience. So to also set the platform for this talk and why I wanted to talk about it is more about my story. And there we go. So first off, I am a Disney lover. So if you don't know, this is a picture of Smee from Peter Pan. Peter Pan was one of my favorite movies as a kid. And one of my long-term goals is to run all of the Disney races at Disneyland, Disney World. So this is from one of those races. But as an athlete, I am no stranger to joint pain. I've had my fair share of joint-related and sports-related injuries. And I have my two kids. My daughter's 4, my son is 2. And when I was pregnant with my daughter, I continued to train and exercise and had the typical back pain issues from pregnancy. And after I had my daughter, had some back pain, neck pain from nursing all the time and taking care of the baby. But after a couple months, it subsided and I didn't really think about it anymore. 9 months later, I got pregnant with my son, and halfway through the pregnancy, I was put on bed rest. So for an athlete, and saying you can't exercise or do anything was really difficult. So I spent 4 months on bed rest, had a full-term healthy baby, and then there's the recovery from having a baby. And that pain I had experienced with my daughter after having my daughter in my back and my neck came back with a vengeance. It was bad. And I was trying to figure out, okay, what is this going on? And I started to talk more to my friends who were moms, family members, and seeing it more in patients in my practice, that a lot of moms were experiencing joint pain months after being postpartum or having a baby, and feeling that they didn't know what to do about it. They were feeling that they would even bring it up to their health providers and they wouldn't really have a solution other than, oh, it'll get back to normal eventually. And that is very frustrating for them to hear. And I feel like through orthobiologics and what we have to offer can really be helpful in this area. So after seeing in my practice and seeing lots of friends and family go through similar experiences, I really started, for me personally, utilizing what I knew. The injection therapies, pelvic floor, and I'll get more into that later. But there's definitely a need for this type of therapy for women after having babies and having joint pain. So when it comes to my screen here, when it comes to postpartum, what is it really? Typically, the first 6 weeks after childbirth, it's become known as the 4th trimester. And it's the time where the body returns to the pre-pregnancy state. So all the physiologic changes that women experience with pregnancy are supposed to return back to normal. But it's not a light switch. It's not all of a sudden, okay, everything's the way it was before. Many women have hormone issues, imbalances, weight gain issues, joint pain issues long after they've had their baby. So there was this one retrospective study from 2021 that focused on pelvic girdle pain and women postpartum. So pelvic girdle, I'm referring to the SI joint, the lumbosacral region, and the pubic symphysis. And what it identified was almost half of all pregnant women reported pelvic girdle pain. And for 20% of women, pain persisted 4 months postpartum after having a baby. And then for 8 to 10% of women, pain continued up to 2 years after childbirth. And that's significant. One interesting thing that was noted in that report was that there was significant improvement with pain scores following SI joint fusion. And they were saying that SI joint fusion is a good treatment modality. In my opinion, that's invasive, right? There are a lot of other great things we can provide before considering a fusion for these women. So we have pregnant women with joint pain, postpartum women with joint pain, and now we have parenting women with joint pain. And I'm going to spend a decent chunk on biomechanics, the body positioning and posturing. This isn't necessarily specific to just women. It's really parenting, being a caregiver, how you have to move throughout your day caring for children. The difference, though, is the physiologic changes the mom goes through combined with the daily posture habits. One thing to consider with women and they're being pregnant, there's relaxin, that hormone that's responsible for preparing the body for childbirth, softening the cervix, but also relaxin is responsible for collagen remodeling. So of course, it's going to affect connective tissues and resulting in ligament laxity. So we have the ligament laxity, we have the body posture changes leading to joint pain. And with there's a small study, only 23 participants, but it's important because they looked at first-time mothers experiencing pelvic girdle pain lasting longer than 3 months postpartum, and for women who didn't have pain prior to childbirth. And there were 4 themes that they identified, and one that almost all but one woman identified with, which is putting up with the pain and coping with everyday life. And that's relates to what I mentioned before, these women with joint pain after pregnancy, putting up with it. The other 3 themes were that they didn't feel back to normal. They had the pain was unexpected and lasting longer than they thought. And then the 4th theme being, what's next for the future? Will they continue to have pain again if they have more children, and so on? With pregnancy, we know that there's increased weight gain leading to increased axial loading. We know that there's an exaggeration in lumbar lordosis, all those being factors when it comes to the pain. So let's go on to the cervical spine. Oh, the slide didn't change. Let's see. Let me see. There it goes. All right. So we see this mom here. She's looking at her baby, and this is a really common positioning for new moms. They are holding their baby, they're feeding their baby in this position, whether they're breastfeeding or bottle feeding. They're looking down at their baby all day. and this is an excessive cervical flexion, similar to what teenagers experience with text neck, right? They're always looking down at their phones. And this excessive cervical flexion results in tightening of the anterior neck muscles. So we have the platysma, scaling, SCM muscles, and that really puts a strain on the nuchal ligament and spinous ligaments in the back. And then what we get concerned about is this repeated position causing a lot of stress and pain in the neck, but then resulting in loss of cervical lordosis. So now we see moms with losing the curve in their neck, that natural curve, and then we get compression of the disc, nerve root compression, osteophytes. So now they're developing bone spurs, and all those being, areas of pain, nerve pain, and so on. The next position is sitting on the floor with the baby. The baby has to practice tummy time, right? Learn to crawl. So the baby's on the floor. A lot of moms change their baby's diapers just sitting on the floor, but it's this constant position, hunching over. So we have the thoracic hyperkyphosis. We have shoulder girdle dysfunction, which relates to upper cross syndrome. So upper cross syndrome, we look at the muscle imbalances. So we end up with really weak, deep cervical flexors, weak lower and middle traps. We have really tight pectoral muscles, tight upper trap, levator scapulae muscle. So this imbalance really contributes to pain in the spine, pain in the head, neck, headaches, for example. And when we have this positioning repeated day after day, with a lot of the ligament laxity from pregnancy, the soft tissues become involved, fascial restrictions, specifically that spiral fascial line can be really affected. And then we get loss of thoracic mobility. So moms are losing a little bit of that rotation in the spine, all those leading back to different pain issues. So now we have the third mom to look at. She is holding, her baby hiked up on her hip, and that's a really common position to hold the baby when you're, if you're cooking or whatever you're doing, holding the baby all day long on your hip. And so what it's creating is this unlevel of the shoulders, a shift in the hips, twist in the rib cage slightly. Again, all this asymmetrical positioning. And then we start developing tendonitis issues. So for example, holding that baby constantly, the same side, same arm, whether it's biceps tendonitis. And then we get more in with the pelvic girdle dysfunction. With the pelvic girdle, where like I mentioned earlier, we also get tight hip flexors and then the weak glutes. So there's this idea with the glutes, particularly the glute medius, as being the main culprit when it comes to weakening from being sedentary. The term that's out there is glute amnesia, but we have moms sitting prolonged times feeding babies, sitting with babies, maybe not as active as they were before they were pregnant, and on top of possibly increased weight gain. So we have this glute medius that's maybe not firing right, putting extra stress on the hips. So again, this isn't necessarily specific to moms. These positions are, all different type of caregivers. It's really thinking about how the physiologic changes affect the joints with the mom in these positions. So now what do? We have some great injection therapies. There are a lot of different types of injection therapies out there. We have a mom, we know she has joint pain. And for me in my practice, I utilize platelet-rich plasma, PRP, and protein concentrate, which is alpha-2 macroglobulin, also known as A2M, the most with my pregnant patients. A lot of women like that it is autologous, meaning it's their own blood. They're using their own blood for healing and their treatment for their tissues. And with the concern for a lot of moms, it's whether the injection treatments are compatible with breastfeeding. You know, if they're breastfeeding, how do these treatments affect the baby and affect their breast milk? A common concern with corticosteroids are that although it is considered compatible with breastfeeding, small amounts do pass through the breast milk. There's also concern if it does reduce milk supply. So for women who have struggled with breast milk production, anything that could possibly reduce their supply is concerning. And a lot of our focus with these treatments is directed towards really overuse issues, not typically dealing with arthritis. Even though arthritis can occur in women in their 20s, 30s, 40s, we're really not seeing that as the main pain generator for for what we're talking about. So as a physician, of course, with physical exams and medical history, it's up to your discretion on what's the best treatment option for your patient. Now, I mentioned the corticosteroids or hyaluronic acid, although it's great for cushioning, isn't really ideal for this situation as well. We're not really targeting arthritis. Dextrose, prolotherapy, D5W, which is a 5% dextrose for perineural therapy, are also really common injection treatment options with pregnant women because dextrose is compatible and pretty gentle. Same with nerve hydrodissections as another common treatment modality. Allograft birth tissue products, exosomes, amniotic fluid, umbilical, things like that. I want to make a note that I had a mom once come to me asking if she brought her placenta to me, can we use that for an injection? And the answer was no, you can't do that. Very different than these, allogenic products that are out there. Another popular injection therapy are peptides. So peptides have become something a lot of patients are asking about as well. I put platelet poor plasma on there because there are some good indications with muscle pain and for patients. And then bone marrow aspirate concentrate and adipose-derived stem cells, which are also autologous treatments coming from the patient's iliac crest, bone marrow, or their fat cells. The harvesting, of course, is another component, right? Harvesting from the patient. Another reason I really enjoy PRP and the protein concentrate for my patients is it's a simple blood draw in office, process the plasma, and then you can move on to treatment same day. The other nice thing about the protein concentrate, the A2M, is that you get a pretty decent volume size when you do a treatment. So we can actually target multiple areas on the joint. We can maybe treat the shoulder and the pelvic girdle at the same time. We don't necessarily need to do just one and then wait a few weeks, do another one. We can really hit a lot of these areas for the patient in one sitting. So I want to go over what I consider the high yield areas. What areas do we want to target for your patient with joint pain after they've had a baby? First is the pubic symphysis. It is a cartilaginous joint. A lot of people forget that it is a joint just because it's not a hinge joint like an elbow. They don't realize that it is a joint, which means it can develop arthritis. You can develop bone spurs. You can have a separation. So a lot of pregnant women and postpartum women have pain in the pubic symphysis. So this is a really great area to treat. One thing to be concerned about is it is a sensitive area, not necessarily because of the location, but the fat pad, the mons pubis, that fat pad is tender when you do an injection there. So that's something to be aware of. The other points of the pelvic girdle that I like to treat with orthobiologics are the sacrotuberous ligament and the iliolumbar ligament and the SI joint. For the goal with these areas is to really try and improve stability within the pelvic girdle, target these pain. These could be really good, really common pain generators for women. Another pain generator in this area that could be a factor to consider are the cluneal nerves. There's the superior, middle, and inferior cluneal nerves. Okay. Next up is the hips. So as I mentioned, arthritis really isn't the main issue. So we're not really targeting the femoral acetabular joint, but we're really targeting the tissue structures around and in the area. Referring back to when I mentioned the glute medius as being a culprit to weakness in the glutes and being a source of pain, is that we end up with a lot of times bursitis. So women can have bursitis in this area. The greater trochanteric bursa can get inflamed, can get thickened, relating to the glute tendons, right? The glute and tendon insertions along here are a great area to treat. A lot of women get pain and tenderness right along that greater trochanter, and these therapies can be wonderful for that. Okay, so we have our shoulder girdle next, which is really comprised of the sternoclavicular joint, acromioclavicular joint, the glenohumeral joint, and the scapulothoracic joint, which a lot of people, again, forget that that is a joint, but scapular dysfunction is really important. I mentioned upper cross syndrome earlier, and how this relates with the positioning with women, right? With hunching over, holding the baby, feeding the baby, sitting on the floor, that scapular dysfunction, what we see is that it progresses to impingement issue. So once we have impingement issue in the shoulder, then we develop rotator cuff issues, which can potentially result in a tear. And once the rotator cuff's been involved, then we get labral issues. So now there could be an issue with the labrum. And I see this progression of scapular dysfunction, rotator cuff tears to labral tears in my practice, because I do work with a lot of athletes, particularly, overhead upper extremity athletes. So when we have this dysfunction, we really want to correct that, right? And correcting scapular dysfunction can help prevent the further degenerative processes of the rotator cuff and labrum. So again, you have a mom holding her baby, sometimes same arm because they may be their right arm dominant, always holding on the left side. But then, of course, we develop the biceps tendonitis, rotator cuff, low-grade partial tears, which is really what I'm referring to. Obviously, if there's a complete tear, high-grade tear, that is something that's a surgical intervention. But for these more low-grade partial thickness tears, tendonitis issues, the orthobiologics work beautifully for that. Also, with the shoulder girdle, I mentioned the impingement. The other target area that's great for treatment is the subacromial subdeltoid bursa. So that bursitis, again, being impinged because of the scapular dysfunction, is a great area to treat. Okay, and the last high yield area that I'm going to speak about is the spine. As I mentioned before, with the interspinous ligaments that take a lot of stress from the body position changes, these are great areas to treat. What we see with the hyperkyphosis in the thoracic spine and the excessive cervical flexion in the cervical spine. So over time with those positionings, what happens is we get a decrease in lumbar lordosis. And once we have that decrease in lumbar lordosis, we get a decrease in range of motion. So the mom potentially is starting to lose mobility in the thoracic spine, and that particularly that rotation. And so being able to move is so important for the health of our spine and our joints. So now we've had strain on those ligaments, we're having loss of our range of motion, and then there's more pain in the back with the mom. Okay. So we have our mom with postpartum joint pain. We know we want to do some injection therapies. We want to do PRP or A2M, whatever it may be. But what else do we have to consider? We have to consider metabolic factors. Are there inflammatory conditions that are going to affect how the body's healing, how it's repairing, and how these repair mechanisms are stimulated? So women, if they have PCOS, hyperlipidemia, obesity, diabetes, autoimmune disorders, just to name a few, it's really going to impact their outcomes, right? How well they respond to these injection therapies. And then what can we do to help improve their outcomes? So for me, I run blood work, pretty comprehensive blood work. I want to see some details on how things are working internally. So whether it is the hormones, inflammation markers, I really like doing the micronutrient testing because moms want to see, of course, like if they're lacking any vitamins, minerals, amino acids, that can affect their nutrition, or, is it dietary or is it absorption issues? But if they're particularly breastfeeding, they want to know, is there something that they're lacking? It could affect their milk and their milk supply. It's really common for babies who are breastfed around 6 months or so, once they start to eat more solid foods and wean off breast milk, to become anemic and to have issues with iron. So same thing with the mom's iron issues. Anemia are common postpartum. So can really try to address any nutrient factors and how that affects their healing with these regenerative injections. Okay, so we want to optimize the healing. And the other thing we need to focus on is the lifestyle changes. For a lot of moms, it's about self-care, and moms tend to put everyone else as a priority but themselves. They'll take care of their kids, parents, whoever it may be, but they put themselves on the back burner. So it's important to help moms realize that this is part of treating their joint pain and take care of their joint pain is self-care. And the better they can take care of themselves, then they can better take care of the patients or people they love. So really helping moms realize that this is important for them, for their long-term health. And for me in my practice, I have athletic trainers that work alongside me that focus on the rehab and corrective exercise. I love working with athletic trainers because they have that a great understanding of the active side, right? Working with athletes, but also how does that translate into daily functioning and getting someone back to being more active and overcoming their joint pain through improving joint function. Another area to focus on is deep belly breathing. Abdominal muscles can get pretty weak from, the automatic sensor just went off with the light in my room, in my office. So deep belly breathing is important because abdominal wall weakness, abdominals get weak from pregnancy. And a lot of times we get into this shallow breathing, chest breathing, and moms aren't really breathing deep through their belly. So kind of re-engaging the core muscles by doing deep breathing, addressing any of the fascial restrictions with myofascial therapies. So cupping, soft tissue mobilization, Graston technique, acupuncture and dry needling, chiropractic care. Strength training program, I think, is really important for moms. Strength training to not only help them long term, that can help with like hormones and weight management, but helping getting their joints protective, right? Long term with joint pain, we want them to get stronger and help their muscles function better. Moms, of course, sometimes get concerned they want to look bulky or they're afraid to pick up a weight, but they're hauling their 20-pound child all around all the time. So they're definitely capable of it, but having a good strength training program to guide them is really helpful. Pelvic floor physical therapy is such a great resource. A lot of women don't know about it, but it's working with a physical therapist who specializes in pelvic floor dysfunction, and they really can help identify improving pelvic floor, because a lot of women think, oh, I just need to do Kegels all the time. But yeah, it's true. If you have a weak pelvic floor, doing Kegels exercises can be helpful. But if the pelvic floor isn't necessarily weak, but it's just tight, then the pelvic floor is so tight that it's not allowed to really do its job. It's not functioning properly. So doing Kegels for that kind of a woman postpartum is the worst thing they should do. So getting a good pelvic floor therapist on board. Nutrition counseling, supporting their diet, which relates back to the micronutrients. And then supportive supplements. There are some nutrients I love that help connective tissues and the joints, especially if we're doing orthobiologics to help the body repair some tissues that might need a little support. Magnesium malate, collagen peptides, zinc, vitamin C, and B vitamins are great for connective tissue, and then amino acids. Okay, so I do have a case to review to give you an idea of what the flow looks like with one of my postpartum patients with joint pain. So she's a 26-year-old female with pubic symphysis pain and pelvic instability, meaning that when she would try to exercise or work out, she didn't feel confident because she felt unstable in her pelvis. She rated her pain severity 6 to 7 out of 10, 10 being the worst. She was 7 months postpartum, so still experiencing this pain months after childbirth. She had 2 children, 3 years apart, both vaginal deliveries, but uncomplicated, so no problems with the vaginal deliveries. She had worked with a pelvic floor therapist, which did have some good results relating to incontinence issues, and she did it after each delivery. She did cupping therapy. She had tried perineural injection therapy, but the provider she was seeing, that was the limit of her injection skills, so she was referred to me. The first injection we did was prolotherapy with ultrasound guidance. Now, I want to pause for a moment and talk about musculoskeletal ultrasound, because really when you're doing these types of injection therapies, it should be image guided, especially the pubic symphysis. If you're going into there, you better know you're in the right spot. So not only is the musculoskeletal ultrasound helpful for the guidance for the injection to these locations, but it's helpful for a diagnostic tool too. You can see the soft tissue structures in real time, tendons, ligaments, things like that. So her first injection, we did the prolotherapy with ultrasound guidance into the pubic symphysis. We were a little bit conservative. I know she was a little concerned about how she would respond. So we did the prolotherapy first. Continued with regular exercise, nutraceuticals. We did a second injection 3 months later, this time doing PRP, platelet-rich plasma, with the ultrasound guidance. I typically do follow-ups 1 month, 3 month, and 6 month after we do the injections. But following her 2 treatments, instability had improved and pain was minimal. So she had pretty great results. Now with PRP, again, you can get even more detailed from there. There's leukocyte-rich PRP, there's PRF out there, which is typically more common in aesthetics, but still, your PRP processing really comes down to, as a physician, what you think is best for your patient. So I'll end with this final note. As a provider and doing these treatments for women postpartum, we're really just a facilitator, right? Doing the injections, we're just facilitating a healing response. But the patient and the patient's body is really what does the real healing. So the work in between injection therapies is just as important as doing the injection themselves, making sure they are supported with a good exercise plan, physical therapy, nutrition plan, cupping, whatever the myofascial therapies are, they're just as important as the injections. So I feel like the best outcomes really come down to that comprehensive, holistic approach to postpartum joint pain. So, all right. Well, if of course any questions, please feel free to reach out to me. It's my email and my social media handles as well. Thank you again for all attending, and thank you to Army for the opportunity.
Thank you, Kelly, for that outstanding talk. I really like how you really reiterated and emphasized how much we're really just sort of facilitating the body's ability to heal itself, right? We're there, and it's more than, a lot of people get really caught up on the needle. The needle is the hand of God, if you will, right? And they forget all the other things that are necessary there to it might be the thing that might spark the healing or might, reignite the healing in that area or that tissue. But it's the fuel that you feed it, the love that you give it, if you will, that really facilitates everything else. I wanted to ask you, you mentioned utilizing prolotherapy and PRP. Just curious, like, how is your approach normally to always start with prolotherapy? And how like, would you use 5%? Do you like to go high, like 20, 25%? And do you, what is your philosophical approach? Do you trying to target all the tissues surrounding it? Can you kind of just elaborate on that?
Sure. So I don't always start with prolotherapy. If a patient is a little bit more sensitive, I will start with a 15% solution. And then usually if we'll do a second round, go up to a 20% solution. I do like to start with prolotherapy for patients with autoimmune conditions. If their autoimmune condition is well managed, they're doing really well. I like to start with prolotherapy just because sometimes if you do PRP, which is considered pro-inflammatory, you could really aggravate a patient easily. So I start with prolotherapy to see how they tolerate it, and then we kind of move up to what I like to say the bigger guns, right, for PRP. But I don't always start there. Some patients, if everything looks good metabolically, and we know we have a little bit more degeneration, like there are some mild tears, it's not just instability, then we need to do something that's a little bit more progressive with the healing mechanism. So PRP is usually a good step. If I'm sensing more of an inflammatory issue, that's why I like the A2M, because it's very anti-inflammatory. So sometimes we'll go straight to that when we know we really need to hit that inflammation, blocking those inflammation enzymes.
Okay. People are asking in general, do you have any thoughts about leukocyte rich, leukocyte poor? How do you utilize them for different targets?
Sure, good question. So a lot of times with the leukocyte rich PRP, I like to do more of the extra articular areas. If we're going intra-articular, I won't use as much of the leukocyte rich PRP, maybe more of the leukocyte poor PRP, and at least in my experience. I would say that would be kind of my approach, depending on what we're trying to target, what tissues there are.
Okay. Curious, when would you decide to move on to something like bone marrow or adipose?
Oh, that's a tough one because it's such a case by case basis, I would say. I think if we're looking at stem cells as an option and we're looking at the health of the patient and they're a good candidate across the board, and we need something a little bit more powerful, then we kind of step it up from there. I don't like to jam treatments too close together. I really want to give the body opportunity to heal. So if we're going to consider something like BMAC or adipose, I'll give it a good 6 months or so, as long as we're working on everything else, to see how they do before we jump up.
Okay. Is 6 months a typical interval period between, like, say, like that dextrose prolotherapy and maybe starting PRP? I'm just curious.
Not typically. I think if it's dextrose prolotherapy, the intervals I would do much closer together. Something like PRP or even the A2M, I would wait a few more months.
Okay. Here's a probably related to, you talked about this multimodal approach, and a lot of people might not even be familiar with a lot of things you mentioned, like Reston and pelvic floor therapy. For the people who don't already utilize this and refer their patients for that, do you have any recommendations on how they can find a good, say, a pelvic floor therapist in their community, or who's the chiropractor, the sports medicine physiologist that you would find it to trust?
Absolutely. So having, for example, with dry needling, like needling techniques, even with Graston, you really want to know if they've had the education for that. It's still a needle, you're still piercing the skin. So you want to find someone who's had a certification in dry needling. Physical therapists, I believe, depending on their state and their scope of practice, whether it's required in their education or not. But finding a good physical therapist that's had that kind of extra education in dry needling. The pelvic floor therapy, same thing. The physical therapist typically has to have that additional education, right? A lot of times with pelvic floor therapy, if you're not familiar with what it is, there's different techniques, but one of the ones they do is like a neurobiofeedback where the probe is actually inserted vaginally, hooked up to a computer. And as the woman goes through contraction and relaxation of her pelvic floor, and you're actually looking to see how is it functioning. And the pelvic floor therapist can analyze that and then determine, what kind of treatments are involved. Some treatments are internal work, which is a very sensitive thing to do. So again, you want to make sure that pelvic floor, that the physical therapist has been trained properly in internal pelvic floor work. And there are some great certifications out there for chiropractors that focus on pregnant women specifically. And I can't remember what it is called off the top of my head, but again, it's that additional education to know that that provider is competent in what they're doing.
Yeah, I think it's really important. I think there's a lot of things that are available out there that people may not even be aware of, and it's also hard to find a good person that you can trust and work with in your community. I don't know if you have any other additional comments or thoughts, Kelly, for this session.
I don't think so. I think we covered pretty much everything.
Okay, well, thank you so much for your time. I hope everybody enjoyed it. Again, I hope you'll come and join us at this conference in February 3rd through 5th. There's a large number of panelists and physicians and coming from all over the country. We have a fantastic keynote speaker who's coming as a professional fighter. And I hope to see you all there. Take care, and thank you for joining us on this Monday afternoon. Thank you, Kelly.
Thank you.
Bye-bye.